Hello, this is Brad, and this is my submission for the second peer competency, my case study submission. I'm going to share my screen real quick. All right, so here's the case. The picture of this patient that I have in my head is that she's a high school aged female athlete that started training recently for volleyball. I think a lot of her problems are stemming from the fact that she has recently become more physically active. And as a lot of young athletes do, she's kind of adjusting to changes in her body. So that could be playing a factor. So I think overall it's a kind of multifactorial, not only in um, so like weakness could be playing a part, hyper or hypomobility, maybe some alignment issues, but also in different regions of the body. So probably the knees, hips, feet might be involved somewhat. So I think overall, a bunch of those factors are kind of contributing to a lot of abnormal loading through the knees and causing stress on those supporting tissues, leading to something like patellofemoral pain syndrome or Osgood-Schlatter's. As far as other examination that I would want to do is there's probably a few more subjective pieces of information I want to get, such as if she can localize the pain, if she was doing any training before starting volleyball drills, and what kind of drills she has started doing since starting volleyball. If she's having any symptoms besides pain, such as swelling, catching, clicking, or numbness. And then I would want to ask more about the stretching exercises that her dad mentioned. Next, I would want to rule out a fracture um, by using the Ottawa knee rules. I'd also want to perform a posture assessment, kind of get a general overview of what her like lower extremity, well, whole body alignment, but mainly focusing on the lower extremity since the primary complaints are about knee pain and hip pain. Included in that, I would want to perform the Craig test to see if there's any kind of excess retroversion or anteversion of the femur. After that, I would maybe observe her perform some functional movements, like squatting or stepping up and down. Along with that, do some palpation to see um, if there are any tender areas, or if I can just with my hands feel any kind of abnormal alignment. After that, I'd want to screen different regions of the body, and I'm not sure how long this would take for an experienced clinician to perform. But if time was a factor, this is the order I would do it in, just in case I wasn't able to get to all these different regions. So I would do the knee first, the hip, the pelvis, and then the lumbar lastly. With each of these screens, I would do passive and active range of motion with forward pressures of the osteokinematic movement. And then I would also do accessory mobility testing of the arthrokinematic movement in each of those joints. Some special tests I could perform would be, so for the pelvis, it would include tests like compression, distraction, thigh thrust, sacral and sacral thrust. And then to rule that out, um, looking for all negatives with those. Some special tests for the hip that I could perform are the Fader or Scar, the Faber or Patrick's. And I could also look at muscle length. So tests like overs for the abductors, Thomas test for hip flexors / quads, and SLR for hamstring length and piriformis length. Some special tests for the knee would include testing ligaments, so ACL, PCL, MCL, LCL, and also testing the meniscus Some specific tests would be like Lockman or anterior drawer for ACL, posterior sag for PCL, Valius and Bear stress test for MCL, and then maybe like a McMurray or Thesley test for the meniscus. After doing those screens, I could perform some manual muscle tests. And for the muscles that cross the knee joint as well as the hip, I would probably focus more on the hip based on my personal experience as being a high school athlete and working with high school athletes. Seems like hip weakness is kind of an issue, but again, that's only on my based on my experience. So not a very low level of evidence there. And then lastly, have her fill out some outcome measures. So something like the LEPS might be useful in this. Some impairments that I thought I might see with this patient are inadequate strength to meet the demand of volleyball drills. So a lot of these like uh, inadequate strength or hypomobility, I look at as in relation to what her body needs to do for volleyball. So it might appear normal, but if it's not meeting the demands of what her volleyball drills are requiring of her tissues or muscles, then I would want to address that. So if she does show some inadequate strength with the MMT manual muscle test, then I could work on strengthening those. I could also work on strengthening in the case of hypermobility to stabilize those joints. In the case of hypermobility, I could use some manipulation or stretching, manipulation for like capsular tissues, and then stretching for musculotendinous structures. And then another treatment idea would be neuromuscular re-ed. If I notice with those observing or doing some of those functional movements like squats and stepping up and down, then I might want to re-educate her on what proper form would be. And then here's kind of my initial plan. Since, as I mentioned above with my hypothesis, that something like patellofemoral pain syndrome is multifactorial in nature, I would want to take a multifactorial approach to treatment, which is what I was reading a lot in the literature as well, that it can't kind of choose one treatment to focus on and go with that. It's kind of incorporating a bunch of different stuff. So like for therapeutic exercise and therapeutic activity, strengthening both muscles that muscles that cross the knee and also the hip slash pelvis. Neuromuscular re-education, as I mentioned above, using some form of feedback for her to kind of visualize or feel the appropriate way to perform movements that she needs to do with volleyball. So like squatting and jumping and passing the ball, setting the ball. Manual therapy. These next two are kind of to address pain. So manual therapy and then patellar taping or bracing. Both aim to decrease pain. Manual therapy would also likely restore some motion if I did find that she's hypomobile with some of my mobility testing. And then lastly, what was recommended in some of these articles was a foot orthosis, but that was more recommended if these other conservative treatments weren't working too well. So I would start off the bat with recommending an orthosis, but something that could be looked into in the future. And then this patient, I would maybe like to see two times per week for 6 weeks. A lot of the literature was suggesting 12 visits, and that was gave the options of 3 times a week for 4 weeks or 2 times a week for 6 weeks. I chose to go with the latter, especially if she is still continuing to participate in volleyball practice, just so that I don't overwork those tissues. Um, and then I would also maybe recommend her not doing some of the volleyball drills if I feel that they're particularly um, stressing the knee or the hip. Okay. So that is my submission for the case study for the second peer competency.